Good afternoon, everyone. We welcome to you parallel session 1.4 on access and equity in family planning at Reprosex 2024, a landmark event hosted by the Family Planning Association of Sri Lanka. I warmly welcome everyone joining here with us today, including our honorable chairpersons, Professor Indralal Balasurya and Dr. Loshan Munasinghe, all presenting authors joining with us physically and virtually. And last but not least, all participants for ReproSex 2024. To begin the session, it's my pleasure to introduce our session co-chairs. Professor Aindra Balasurya, Chair Professor of Public Health and Dean of the Faculty of Medicine at KDU. Professor Balasurya is not only highly respected medical doctor and public health specialist, but also a researcher with over 125 publications. His wide-ranging experience in reproductive health, family planning, and community medicine has greatly enriched the field he serves, both in Sri Lanka and internationally. Joining him is Dr. Loshan Munasinghe, a medical doctor from a Family Health Bureau at Ministry of Health. Dr. Munasinghe serves as a focal point for Sri Lanka's National Family Planning Program. He brings over 28 years of experience in reproductive health, women's health, and family planning, with many contribute to international journals. His wide knowledge and commitment to improving family health and equity continue to make a difference at both local and global level. Now I am delighted to hand over the session to our distinguished co-chairs, Professor Indra Balasurya and Dr. Loshan Munasinghe. Thank you.
Good afternoon and thank you for the introductions. I will just give the ground rules for the presenters. You have 10 minutes for presentation, and after 8 minutes, one bell will be rung, and at the end of the 10 minutes, two bells will be rung. So you will have to stop by 10 minutes, and Q&A session will be at the end of the presentation of all the papers. The last presentation is online. So after that, we will have the common Q&A presentation. So please fix to time, and I will invite my friend Dr. Loshan Munasinghe for the introduction of the first presenter.
Thank you, Professor Balasurya. Good afternoon to you all. It's my pleasure to introduce Dr. Jayaratna, currently attached to the Adolescent and Youth Health Unit, Family Health Bureau, Ministry of Health. She is a postgraduate trainee, registrar in community medicine. She obtained a MBBS degree from the Faculty of Medicine, Ruhuna, in 2012, and she has had 2.5 years of experience in public health. She has also been a medical officer of health in Deranegala in the Kakala district. She has completed her community medicine masters in 2019. She now works at the Family Health Bureau as a national level focal point for maternal and child health, and is responsible for planning, coordinating, monitoring, and evaluating the reproductive, maternal and child health and adolescent health programs in Sri Lanka. And her topic today is on male involvement in family planning in a rural setting in Sri Lanka. Over to you, Dr. Jayaratna.
Good evening, everyone. So, I'm Dr. Nadika Jayaratna. So, my topic is male involvement in family planning in a rural setting in Sri Lanka. So, family planning is a decision within the family where both the partners contribute. But traditionally, it is considered mostly a women's affair. But men also should be considered as equal partners in reproductive health. So, what is meant by male involvement? It is that they are as clients in family planning services, partners in decision making, and their supportive role for the partners' use of family planning, and finally as change agents for a better reproductive health care and gender equity. So this male involvement is influenced by their knowledge, attitude and perceptions towards contraception, and it eventually helps achieving high contraceptive prevalence rate as well. So in Sri Lanka, though we have a high contraceptive prevalence rate, it has been stagnant over the past years, and services are considered as mostly female oriented. So lack of communication strategies to reach men. There's less data related to male involvement in family planning as well. Okay, the methodology is, the sampling method is a multi-stage cluster sampling method. There were 16 clusters. One PHM area was considered as one cluster. So the first household was selected by simple random method. Then the other houses are selected by stratified sampling method. So the pre-tested interviewer administered questionnaire was used. Interviews carried out in the households of the participants. So these are the socio-demographic characteristics of the sample. Among the participants, their mean age was 32.7 years. Majority was Sinhalese. There were 19.4 Tamils and 83.3 from rural areas, and others were from the estate areas. Regarding their employment, all were employed and from extended families. And then majority of male spouses, 99.2, had, when we inquire about their knowledge on family planning, so majority of the male spouses, 99.2 of them, had ever heard of family planning. And the mean number of contraceptive methods known by a male spouse was 2.5, and there were 52.5% of participants who knew more than 3 methods. So benefits of family planning methods as mentioned by the study participants. So when we inquire them about what are the benefits of family planning method, high percentage of them, 53.8 mentioned about maintaining adequate gap between pregnancies. Another 35.7 mentioned about limiting the number of children in the family. 35.5 mentioned about preventing unwanted pregnancies. 18.5 mentioned about deciding the correct time to have children. Here multiple responses were allowed. And then their knowledge about different methods. Highest percentage was recorded for male condoms, 92.4. 65.3 of them were aware about oral contraceptive pills. 32.6% aware about hormonal implants, and 17.6 about the injectables. The least awareness was about female condoms. And when we asked about their knowledge on various aspects related to family planning, so when we asked about do they know about family planning services are being freely provided in Sri Lanka, 74.8% of them knew that it's been freely provided. There were like 65.4 who believed that family planning practices cause infertility. When we inquired them about that can missing oral contraceptive pills result in pregnancy, 70.8 of them thought can happen, and there were 29.2 who thought it's not possible. About legalization of abortion, so there were like 72.3 thought it is legalized. And then regarding the using of condoms and prevention of STIs, so only 41.4% of them knew that it can prevent sexually transmitted infection. And about the possibility of getting pregnant while breastfeeding, initial 6 months, so only 10.8% knew about, and there were like 56.8 who thought they can use emergency contraceptive pills as a regular method. So in the overall assessment of knowledge, 33.1 study participants had satisfactory knowledge on family planning. Majority, 66.9, had unsatisfactory knowledge on family planning. And then we assessed about their practices. So among the male spouses, 15.4 were currently practicing any method. So out of male spouses, majority like 79.4 were using condoms, and 19% were using natural or traditional methods. Regarding the attitudes, 83.8 approved using family planning methods by male spouses. 75.4 approved female spouses using family planning methods. The commonest reason for not approving family planning was the fear of side effects. And then the major concern was about the subfertility or the infertility. 20.3% believed it can cause subfertility. 78.6 agreed that male participation is important in family planning, but only 39.2% had a favorable attitude towards males attending family planning clinics with their spouses. In the overall assessment of the attitude, unlike the knowledge aspect, 56.9% had favorable attitudes towards family planning. Only 43.1 had unfavorable attitude. So there was a difference between this knowledge aspect and the attitudes. And then regarding the decision making related to family planning, here we had a questionnaire assessing whether they discussed about this family planning with their spouses, when they first discussed about this, and when accepting the method, do they discuss with each other, and whether the male partner attended the clinic with the female spouse. Those things we assessed. 64.7% of male spouses had a good involvement in family planning decision making. High percentage, 92.2, had discussed family planning methods with their spouse. Out of those, 44.3 had discussed it for the first time after their marriage, and another 44.3 after having the first child. Here are the associated factors with the male partner's involvement in family planning: the residence, ethnicity, age, monthly income, age at marriage, and duration married, and especially the knowledge on family planning had a significant association with their involvement in family planning decision making. So the conclusion is that high percentage had unsatisfactory overall knowledge on family planning, but they had a high percentage had a favorable attitude towards family planning and had good involvement in decision making related to family planning. So the recommendations are increasing the participation of males during our family planning programs, incorporate men as an integral part of the target audience during health education sessions, and public health midwives to convey the messages during their home visits, and encourage male spouses clinic attendance with their female spouses, including both the partners during family planning counseling sessions. Thank you very much.
Thank you, Dr. Nadika, keeping up to time. It was eye-opening presentation on male involvement where there is a knowledge gap, though the attitudes are good. Over to you, Roshan.
The next presentation is on unraveling the factors determining traditional family planning practice among ever married women in Sri Lanka. This is by Migara Karunaratna, who is a senior lecturer attached to the Department of Demography, Faculty of Arts, University of Colombo. Currently, he serves as the treasurer of the Population Association of Sri Lanka. He obtained his Master of Science degree in Business Statistics from the University of Moratuwa and Bachelor's degree from the University of Colombo. His key research areas are sexual and reproductive health, LGBTQ+, community-related health and well-being, and demographics of minority groups. Over to you, Miguel.
So thank you very much. Very good afternoon to you all. So today I'm going to talk about the unrevealing factors determining traditional family planning practices among ever married women in Sri Lanka. As they explained me, I am Migara Karunaratna, so I am attached to the Department of Demography, Faculty of Arts. When it comes to the introduction, effective family planning is influential in improving the well-being of both the mother and child. So as we all know that most of the families or couples are using birth controls or family planning to delay or spacing or limiting their childbirth. Globally, according to WHO, the family planning eliminates 1/3 of the deaths related to the pregnancy and nearly 45% of neonatal deaths. This is due to the suitable family planning interventions in timing and spacing of the pregnancies. However, compared to the modern methods, we all know that the traditional family planning methods failure rate is quite high than the modern methods. So we all know that in generally we are practicing both methods in Sri Lanka. So notably, it is important to emphasize that Sri Lanka has been documented as one of the nations with highly who depend on traditional family planning methods according to the Ministry of Health in 2019. Nevertheless, still the motives for that or the usage of traditional methods have been not investigated statistically. So with that kind of objective introduction, so my main objective of this study is to identify and modeling the significant or influencing factors which affect on practices of traditional family planning methods among ever married women in Sri Lanka. With regard to that, my methodology was taken. I have taken the data from by using secondary data, which data collected by the Department of Census and Statistics for the Demographic and Health Survey, which was conducted in 2016. So this is the latest Demographic and Health Survey which was conducted in Sri Lanka. This is the up-to-date data which I can take from the DCS. Sample size were 10,835 ever married women. The technique was I used binary logistic regression model for incorporate to identify what are the factors which affect on traditional family planning practices. Dependent variable was traditional family planning users and modern family planning users. Independent variables were selected under 3 categories as demographic, socioeconomic and programmatic factors. When it comes to my explanation with regard to how I assess the knowledge of family planning, there were several questions. There were 12 questions questions asked at the demographic and health survey which regard to the knowledge. So according to them, I have scored them as 1 for the correct answers and 0 for the wrong answers. Out of that, I have scored and divide into 3 categories, and good, moderate and poor knowledge. When it comes to the results, so I will briefly explain about demographic, socioeconomic background and their differences about the respondents by traditional family planning methods and modern family planning methods. According to the distribution of their ethnic characteristics, you can see there are no such a huge difference. But when it comes to the quintile of the respondents, you can see the highest of the who belongs to the highest wealth quintile are using traditional family planning methods than the modern methods. When it comes to the employment level of the women, the ever married women, you can see in these last two occupational categories, you can see highest percentage than the modern family planning users belongs to the quite higher levels of employment categories, those who are using traditional family planning method. And also when it comes to the age distribution of the traditional family planning users, you can see quite higher percentage than the modern family planning users in quite higher age categories, especially in 33 to 41 and 45 to 50 years of women. And also when talking about the sectoral distribution of the respondents, you can see quite urban women are having high proportion to using traditional family planning methods than the rural respondents. But when it comes to state sector, you can see higher modern methods usage among state sector women. And also when it comes to the distribution of number of children among those users, you can see the majority, quite higher percentage can be seen among those who are within childless women have using traditional family planning methods than the other 2 categories. This is the main outcome of my research. So according to regression analysis, I have identified, according to my basic 3 subcategories, according to the logistic regression model, the predictive power of the model is 82.9%. Among that demographic factors, knowledge on family planning, women's ethnicity, decision to use family planning, women's religion, women's age and their education level, and also the number of children are affect for their traditional family planning usage. And also under the socioeconomic category, occupation of the spouse as well as occupation of women and wealth quantiles are highly effect on traditional family planning usage, and also which belongs to the programmatic factors, attending to well women clinics and taking advices from public health midwives are effect on traditional family planning usage. So this is the final model I took from the regression analysis. So when it comes to the odds ratio analysis, you can see actually I am talking only few points because due to the time. So odds of the practices of traditional family planning is 2.6 times and 1.33 times high respectively among women, those who have moderate knowledge and good knowledge than the poor knowledge on family planning methods. So with having some sort of a good knowledge means that they are trying to use traditional family planning methods than the modern method. And also when it comes to the decision to use family planning methods taken by both together is 4.26 times higher than the decision those who are taken by taking advice from the midwives. And also odds of practices on traditional family planning are 1.88 times and 2.33 times and 1.48 times advanced respectively among women who are in the age group of 23 to 32, 33 to 41 and 42 to 50 years than the who are in the below lowest age groups in the Sri Lankan ever married women's category. And also the practices of traditional family planning among women who are working as sales, clerical, machine related workers and industry are 1.2. So traditional family planning practices by number of children, the odds indicated that traditional family planning practices among women having 1 to 2 children and childless women are correspondingly 3.9 times and 1.4 times higher than those who are having 3 or more children. And also the last one, the odds indicated that women's in highest wealth quintile, it means 1.237 times, and women lowest wealth quintile are practicing traditional methods than the women belongs to the moderate wealth quintile. Within the conclusion of my presentation, women's knowledge on family planning, women's level of knowledge, number of children, women's occupation and women's wealth quintiles are mainly influenced on practices of traditional family planning methods. Therefore, the revealed factors are strongly evidence-based and geared towards providing a contemporary, powerful solution for all the policymakers. So, consequently, the key female groups in need of contraceptive facilities and awareness can be targeted targeted more resourcefully and effectively. So, as a recommendation, the Family Planning Association of Sri Lanka and Family Health Bureau and Ministry of Health can plan awareness sessions to be directed by medical doctors and midwives by targeting those women in reproductive age span in Sri Lanka and forming promotions and counseling sessions on modern contraceptive methods in different sectors and different fields, which we have to target male ever married women, and also organizing all kind of media awareness campaigns to dispel the myths of surrounding modern family planning methods can be recommended. So thank you very much.
Thank you, Mr. Migara Karunaratne. He talked about an important aspect of family planning which has been neglected so far. So I think you will have a lot of questions at the end. Now, Roshan, over to you.
Thank you. May I present the next presenter, Dr. Pallavi Sonu. She is going to present on exploring service provider perspectives on LNG intrauterine system deployment in Family Planning Association of India clinics. She is a public health professional working with Family Planning Association of India since August 2022 in the capacity of Program Manager Medical. She has been in the field of public health for over 7 years. She has an experience of working in public and private sector in managing and leading program activities with focused work around maternal health. At present, she is leading clinical services delivery implementation through clinics of FPA India. Thank you. Over to you.
Good afternoon, everyone. So I will be presenting on exploring service providers' perspective on LNGIUS deployment in Family Planning Association of India clinics. So along with me, there are 4 other authors from Family Planning Association of India who have contributed to the work. So LNGIUS is levonorgestrel intrauterine system that is placed inside the uterus. So it is similar to copper IUD, but this is a hormonal IUD kind of, which contains 52 milligram of progesterone, that is similar to the female sex hormone. And once it is inserted, so daily 20 microgram of IUS is released inside the uterus. The effectiveness of LNGIUS is, it is a contraceptive, and along with that it is also used as a treatment for menorrhagia or endometriosis. Now, according to the NFHS 5 national data, so around 56.5 women of the reproductive age group were using modern methods of contraception, and among them only 2.1% of them were using IUD or postpartum IUD. In India, the contraceptives majorly which are available are injectables, condom or oral pills. Recently, implants are also available through government sector. But LNGIUS is something that is only available in private sector, and it is very expensive commodity right now. So FPA India introduced LNGIUS to its basket of choice contraception since around 4 or 5 years. But this LNGIUS which I am going to talk about was donated to us by ICA Foundation, International Contraceptive Access Foundation, since 2022. We have been using it as a contraceptive and also as a treatment for heavy menstrual bleeding. So my objective of this paper would be to assess the perspective of service providers in introducing LNGIUS in FPA India clinics. Family Planning Association of India was founded in 1949, and currently there are like 44 clinics pan-India, and of this around 15 clinics were provided with LNGIUS, and among them also we chose 6 clinics basis the monthly service statistics and the geographical locations of this clinic. Those are based in West Bengal, Karnataka, Uttar Pradesh, Gujarat and Madhya Pradesh. In-depth interviews were conducted with 6 medical officers and 6 counselors. So total of 12 persons interviews were conducted to understand their strategies, how they can introduce LNG, how they were introducing LNGIUS into their clinics. So further to that, thematic analysis was conducted on this. The information which was recorded was mainly how the uptake of LNGIUS was taken up in their clinic, how was the follow-up process followed with the clients, and what challenges they were facing with the clients. So through my findings, first is that the demand generation and counseling is a major part of it. So when these clinics had introduced LNGIUS, so initially counselors were having a bit of reluctance through the clients that this is something that is being inserted into the uterus. So already there are many misconceptions about IUDs. This, along with this, again now IUS is something similar to IUDs. this is also inserted into the uterus. So how effective will that be? So there was initial reluctance by the clients. So therefore, multiple counseling sessions were required with the clients, convincing them that this is a contraceptive, and also for the clients who were facing heavy menstrual bleeding. So for them, this is also a treatment option. So further, when this was taken up by clients, so after multiple follow-ups, after 6 months, then after a year, so clients expressed that they were satisfied with this system that was being inserted inside the uterus. So most of the providers, when after providing to the clients, they emphasize that counseling is a major part, because once the counseling before insertion is being done for the clients, then afterwards when there are bleeding changes with this LNG-IUS, so clients who are facing heavy menstrual bleeding, so there is a reduction of bleeding, and after some time some clients face amenorrhea. So this counseling, if it is done before insertion, so it helps the client to understand that what changes their body will be undergoing, and then they can cope up with that. In the way for the demand generation, so awareness is most important things. Local health workers like Ashas and Anganwadis were also involved into this and sensitized for this LNG-IUS system, that this is something that is available as a contraception and also as a treatment option. So some clients who they know who are facing any heavy menstrual bleeding, so they could send them to the clinic, and this option could be also adopted by them instead of a medical treatment option or a surgical treatment option. So we had developed informational material also, so I will show you on the next slide. So that is also helpful for making understand the client, or referring for by the counselors to make the clients understand that what system this is and how different it is by other than the IUD. Counselors also use the contraceptive also to show them how this is working, or how does it look, or how it is being inserted inside the uterus. So this makes them helpful to convince the client for adopting this method. So in terms of provider perspective, so this is mostly by the medical officers that we are looking at. So almost all the medical officers showed a positive attitude, because they understood what is the difference between the IUD and the LNG-IUS, how the mechanism of action between both of them is, or how the bleeding profiles are different in both of them. So they had a positive attitude in incorporating this LNG-IUS into the system. Also, almost all the providers, so this being where we provide services for contraception, and along with there are gynec clients also coming in. So it was helpful for, providing this system as a method of option other than the medical and the surgical option, that this LNG-IUS can be inserted and removed whenever the client is ready to remove it. So without any, everyday reminder of a pill or something, or undergoing a major surgery. So this option was helpful for them. So whenever for the insertion and removal process, so trained practitioner is required. So staff nurse cannot be possibly doing the insertion for LNG-IUS. So almost all the providers were easy. They were comfortable while inserting and removing the LNG-IUS, and they found it similar to IUD. But there was just a minor difference in this insertion of the LNG-IUS. So non-contraceptive benefits of the LNG-IUS, then it had fewer side effects, and also there were positive testimonies from the client. So coming to the client satisfaction, clients were highly satisfied with this LNG-IUS. So this we got to know once the clients, when they had inserted, so they were continuing with the method. There were less removals of LNG-IUS. So this is one way that we were understanding that they were highly satisfied with the LNG-IUS, and also those who had used it for HMB, so they had noticed the reduction in bleeding. So this is on the left hand side, you can see right hand side. So this is one of the poster that we had developed for differentiation between IUD and LNG-IUS. So these are some of the testimonials of the counselor and medical officer. So one medical officer mentioned that clients were happy with LNG-IUS, so as it was a substitute to medical and surgical treatment. And counselors also mentioned that all clients do not accept bleeding changes, as it requires multiple counseling sessions. And another counselor had mentioned that initially multiple counseling sessions were required. However, after some months, it was easier to explain other clients and community due to community feedback. So in conclusion with the findings, so community meetings were helpful for the, implementing this LNG-IUS into system, and counseling also plays a vital role, as it makes the client comfortable before inserting, and then be aware about what bleeding changes can happen. This LNG-IUS has non-contraceptive benefits, and also it is beneficial in improving anemia, and it is a long-term solution, and it does not require daily attention to it, and it enhances the quality of life. So lastly, in recommendation, it is share the positive outcome. Yeah, so these are the references, and thank you everyone for listening.
Thank you, Dr. Vinakar, for that interesting qualitative research. We will go to the next presenter.
The next presentation is by Tapasi Grahacharya, who is a project manager for FPA India, and she's been there for 6 years. And she has done a master's in social work and also a postgraduate diploma in management. And her presentation is on overcoming the social cultural barriers for accessing family planning service by communities through informed choices in Noida slums in India. Over to you. Thank you.
So this is a project we are implementing in Noida since 5 years, and I am sharing the outcomes of the project. So the title is Overcoming the Socio-Cultural Barriers for Accessing Family Planning Services by the Communities of Noida through Informed Choices. So these are the co-authors with me who contributed for this. Noida, it's a systematically a planned city actually in Uttar Pradesh. Among the 75 districts, this is one of the district, Gautam Budh Nagar, in which Noida and Greater Noida are twin cities. And household, there are 1,53,000 household with a population of 6,37,000 as per the census 2011. This accounting for 24.13% of the urban population as compared to the 2001 census. This is 37.1% rise in the population of in 2011 census. According to National Family Health Survey 4, Gautam Budh Nagar slum, there are contraceptive prevalence rate is 74.6%. 48.4% use any modern contraceptive methods. But as per our baseline survey, when we conducted our baseline survey there, it's much less, and we found it 28% among the currently married women in the age group of 14 to 49 years of age group, and only 27% of the females are using any modern contraceptive method, and among the male it's 30%. So the objective is to increase the modern contraceptive prevalence rate by 30% from the baseline, and to enable the young people to make informed choices regarding contraception and by overcoming the socio-cultural barrier. So this is the methodology under which the project did. One is baseline household survey. It's conducted in 2011, and under baseline household survey we conducted in 2 phases. One is mapping and house listing and individual interview, and under impact assessment we conducted focus group discussion and individual interview. So this is some key findings of the baseline, like education status. This is the graph I have mentioned, and the coming to the knowledge and family planning methods, the male have on 68% male have know about family planning, 53% females know about the family planning. This is the occupations and wise percentage graph for the what we found in baseline. Coming to the contraceptive users, in the baseline we found 15 to 19 years male and female both are not using any family planning methods, and among the females in the age group of 20 to 24, only 7% female are using contraceptive users methods, and only 3% male are using any contraceptives in the age group of 20 to 24. And this is under impact assessment, the male and female in the age group of 15 to 19 years, it increased to 29%, and 46% females in the age group of 20 to 24, they are using contraceptives, and 42% male in the age group of 20 to 24, they are using contraceptives. So these are the strategies used to improve the family planning services and promote the methods among the communities in the Noida slums. So mainly the demand generation was done through home visits and through group sessions, female group sessions, couple group sessions with the parents, with the in-laws, with the daughter-in-laws, mother-in-laws, and doorstep delivery of family planning information and contraceptives, mostly condoms and oral pills. Then liaising with the public health facilities and accompanied referral for the injectables, IUCD insertion and sterilization, and imparting comprehensive sexuality education to the youths and adolescents, training of peer educators, community-based providers, and frontline workers. Information, education, communication, and behavior change communication to address the barriers years to increase the family planning services in Noida. So, if I'll coming to the what barriers, mainly the barriers what we found are the religious practices regarding contraceptives, the refusal on the part of the partner, either of the partner, maybe male, female, for using contraceptives. The perception, family planning is mainly female affair, low involvement of the male, and the societal and family pressure to having more children, like to have mainly boys, and if somebody has more boys for girls. So these are the mainly these are the socio-cultural barriers. So the contraceptive prevalence rate has been increased from 28% to 54%, and among the couples, among the female 15 to 49 years, it's increased. Among the male in the age group of 15 to 54 years, it has been increased to 57% as compared to 30%. In under the qualitative outcomes, we found before when we initiate the project in the area, people were very shy to talk about the family planning and sexual and SRHR issues, and they have very limited knowledge and awareness regarding SRHR and family planning issues. But now the awareness level, especially among the females, have been increased, and voluntarily they are coming and accessing family planning service in our centers, and even they are bringing their male partners for counseling. This is the outcome of this is the result of increased level of awareness on family planning methods. Like the knowledge and family planning methods have been raised among the males from 68 to 89%, and among the females it has been raised from 53 to 78%. So coming to the conclusion, what all works to increase the family planning services in that area: spreading positive messages on family planning and sexual and reproductive health rights through information, education and communication sessions. Individual counseling and group counseling have their own benefits, and they play major roles in motivating the couples for using family planning services and methods. Family planning users as a motivators for the potential client to take up family planning services, using male family planning users as goodwill ambassador to motivate other males and couples to take up family planning methods. Mother-in-law's confluences, because they are the head of the family. Sustainability point of view, training of the youth, peer educators, frontline workers, community-based providers as family planning educators. Coming to the recommendation, community mobilization plays a crucial role for overcoming the social cultural barrier for promoting family planning methods, and innovative approaches such as experience sharing by satisfied family planning users, group session, individual counseling through home visits by CBPs, couple counseling plays important role for increasing the family planning methods. Thank you.
Thank you, Grabacharya, for the action research, very successful work. Over to you, Lushan.
Thank you. So the next presenter is Vaishnavi Gengatheeswaran, and she's a fourth year medical student at the Faculty of Medicine, University of Jaffna. As a first time researcher, Vaishnavi is focused on the knowledge and practice of contraceptive methods, and her presentation is on knowledge and contraceptive methods among reproductive age mothers attending a tertiary care hospital in the northern parts of Sri Lanka. Over to you.
Thank you for the introduction, sir. Very good afternoon to everyone. I'm Vaishnavi Gengatheeswaran, a fourth year medical student from Faculty of Medicine, University of Jaffna. I'm thrilled to present my study on knowledge and practice of contraceptive methods amongst reproductive age mothers who are attending a tertiary care hospital in the northern Sri Lanka. The first problem that we identified is that in Sri Lanka, even though the government and NGOs are providing a lot of services to enhance the usage of the contraceptive methods, still the unplanned pregnancies and unsafe abortions are in the higher rate. So we wanted to find that we are giving the service, why is not getting to the people? It's what is the problem between the knowledge and practice among them? So our primary object or general objective was to assess the knowledge and current practices of contraceptive methods amongst reproductive age mothers attending a tertiary care hospital in northern Sri Lanka. Our specific objectives were to determine the prevalence of contraceptive use amongst women, to determine the knowledge of side effects, contraindications, proper usage of contraceptives, to identify the socio-demographic factors, how they influence the knowledge and prevalence of contraceptive methods amongst women. So our methodology, the study design was a hospital-based descriptive cross-sectional study, and the study setting was conducted in the pediatric hospital and teaching hospital Jaffna, and the study population population were the mothers who are aged from 16 to 49 who were staying at the pediatric wards at our data collection period. And the study period is given here. And we have excluded the mothers who of the critically ill patients, and we have excluded the repeated admission during the data collection period. Sample size was 389, and the sampling technique was systemic sampling method, and the study instrument we used was an interview administered questionnaire because there was some technical wording in the questionnaire. And the data analysis we have done in the SPSS 26 version, and in the results the total response was 359 with a response rate of 92.3%. And among them, when we take the mean age, 33.7 was the mean age, and the age distribution of the participant and the partners are given in these two histograms. And in the socio-demographic factors, most of them were Hinduism followers with the 68%, most of them living in a nuclear family, and their education level, the most of them have education level above the GCOL, and the monthly income of most people is less than 75,000. And the occupation, if we consider each occupation person separately, housewives are the most common people. And the number of children the people are having, 2 or less, 74%. And almost all of the participants, that means the 98.3 participants, were aware of the concept of contraceptive methods. Amongst them, most of them show familiarity with condom, followed by oral contraceptive pills, intrauterine devices, and injectable devices. And most of them got the contraceptive was given from an MOH office. And only 198 participants were practicing some type of contraception at the period of our study. And we assessed the knowledge of the contraceptive method using 19 questions in a questionnaire. The least score from 0 and the highest score is 16. The mean marks was 5.82, and the histogram is given here. And there are 198 people who were using contraceptive methods during that period. Among them, 21% were using sterilization, followed by implants, condoms, injectable contraceptives, oral contraceptive pills, IUCD, and the least of them are using the natural contraceptive methods or any other methods. 155 people were not using any contraceptive methods at that point. Most of them were due to the fear of the side effect. 34% not using any contraceptives because of the fear of side effects. Other than that, 23% are not even telling the reason. They don't know why they are not using any contraceptives. That is the main issue within this age group people. And then it is followed by the planning to have children soon, cultural religious belief, partner disapproval, and the least amount of people are not using because previous negative experiences and lack of awareness. Here the main thing we have to see is the fear of side effect is 34%, but the people who actually had a negative effect previously are only 3%. And when we are taking the users, when we asked about the side effects, only 52% had the weight gain, then followed by irregular excessive bleeding, and least amount of people are having headache or spotted bleeding or nausea or breast tenderness. So in the total amount of people who are currently using contraceptive methods, only 35.9% have ever had a side effect, and only 21 people are used the contraceptive pills, and most of them were, the reason was unprotected sexual intercourse. Some of them didn't know about that concept, and some of them have already used it as a regular contraceptive method as well. And only 6% have encountered a contraceptive failure. One thing is missing here, only 79.7% know that condoms can prevent the STIs. And the relationship between socio-demographic factor and the knowledge, when their education is higher than the GCO level, their knowledge is very significantly correlated with a p-value of 0.002. And when the monthly income is more than 75,000, there is a significant correlation with the p-value of 0.007. And when the occupation of the participant is other than being a housewife, they have a correlation with the p-value 0.046. In other factors, we expected to get some correlations, but we couldn't get. And the relationship between socio-demographic factors and the use of at least one contraceptive methods, when their children's number is more than 2, they are using more contraceptive with a p-value of 0.004. And when their monthly income is less than 75,000, there is a correlation with the p-value of 0.014. Here is a contraindicating factor. In the knowledge, when their income is more, they are having more knowledge. But when it comes to practice, when their income is low, they are having no practice. This is maybe probably due to they can't afford to have another child, or our healthcare assistants or midwives are more familiar with them to talk to them. And the highest education level, when the partner's highest education level is less than GCO level, that also have a correlation with the p-value of 0.032. And the other factors didn't have any correlation. In conclusion, even though the many participants have the knowledge or have the idea about contraceptive methods, when we ask about the in-depth questions, their knowledge is very poor, and there's a serious lack of knowledge regarding the emergency contraceptive pill as well as contraceptive used in the prevention of STIs. Next one is regarding the practices. The study revealed that a significant proportion of the population was currently using a form of contraceptive, and the failure rate is fairly low. So the people who are using are getting more benefit. And the study also highlighted the socio-demographic factors affecting the knowledge and practice of contraceptive methods. And our recommendations are, primary one is we have to give education on mainly three things. First one is the side effects of the contraceptive. In the side effects of contraceptive methods, it's really important to give that knowledge, as I told earlier also. And the knowledge should be given to the eligible couples, because in Sri Lanka, giving it a school education is not possible about contraception. So to the eligible couples, the education should be given by the healthcare professionals. And our second recommendation is steps must be taken to debunk the social taboo surrounding contraceptive usage at the community level. Because during the research, we found that they were ashamed of talking about the emergency contraceptive pill and STI. So the social taboo should be broken. And the other one is the incorporating modern techniques such as social media campaign will be beneficial, as it will attract more younger population. These are my references. Thank you.
Thank you, Ms. Vaishnavi. I think your team is also here. So you have done a good study on some uncharted territory. Now I invite the last to introduce the last presenter.
So the next presentation is online. It's by Dr. Lopamudra, and she is based in Pathfinder in the India office in Delhi, and she serves as the male lead for India. She holds a PhD in population studies from the Jawaharlal Nehru University and has 18 years of experience in the development sector, focusing on family planning, SRHR, maternal and child health, and neonates, communicable diseases like TB. Her expertise lies in designing and implementing MEL frameworks and research on social behavioral change communication, behavioral dynamics, gender and social norms, and digital health. She has worked with donors like UNICEF, USAID, BMGF, CIFF, private sector donors. She also serves on several ethical review boards in India, overseeing research involving human subjects. And her topic and presentation is on measuring reproductive autonomy among married youth in India, a new model. Over to you.
Hello everyone. Today I'm going to present about reproductive autonomy among young women in India and how we have measured through a project called BMJ funded project in India called YUVA. Before that, I would like to go for my introduction. I am Lopamudra, Dr. Lopamudra Paul, who is working as a director leading the MEO, Monitoring Evolution and Learning in Pathfinder India Country Office based in New Delhi. And before we start our presentation, you should know that what is called reproductive autonomy. So it's defined as to having a power to decide on and also control the matter about your pregnancy, childbirth, and also it actually based on the overarching concept women empowerment, and which is defined as that woman's ability to make their own life's choice. Further, I would also wanted to say that this is also should be one goal for woman reproductive intention, which is influenced by the relationship with her sexual partner. So, but that varies with the culture, the context, the environment where she lives in. Going further, I would also wanted to show that the conceptual framework, which has been adapted from renowned work which has been published in 2014 in Studies in Family Planning by Dr. Upadhyay and others, that how women's reproductive autonomy has been influenced by self-efficacy, decision-making power, communication ability, equitable gender role in an attitude, management of coercion, and then how it has been gone for the ability to control for spacing, timing, and number of pregnancy and birth. So if we we can have all those things together with the support of the community, their family, other individual around them, then there is an achievement of reproductive intention. So in this particular model, we have constituted based on the 14 criteria, which is broadly divided in 3 criteria: freedom from the coercion, communication between the partner, and the decision making. That has been the 5, 5, and 4 has been all indicators. It is on the screen. I'm not going to basically discuss more on this, that how this, but all the indicator has been weighed and given the weightage, and then it has been calculated and used for the constructing the reproductive autonomy scale. So in India, we have conducted a survey post and pre within the gap 3 years to see the reproductive autonomy in 10 districts span over 5 each in Bihar and Maharashtra. One is the eastern states, which is Bihar, and one is the western states, which is in Maharashtra, to understand that how this reproductive autonomy has been helped people to increase the contraceptive use in a married couple and the first time pregnant. It was in a cross-sectional mixed method study and structured with a questionnaire, which was interview questionnaire, which is methodology has been adapted from Dr. Upadhyay's model. We collected responses from the 229 currently married women and covered over the across that rural and urban area. In a nutshell, we have seen that 70% women do not agree with any of that they have in the contraceptive, any of freedom from the coercion having the pregnancy. So it's going to be very higher side. You can see it here. It's very fairly high. And also from the 60% said that they have the spousal communication and the contraceptive use. And the 70% women have said that the power of the decision making. So it is very evident. When we are going for a survey, going with the measuring scale, we found it out that people have always saying, yes, we have freedom, but there is more to understand. So when we are going for, the majority of them has told that they are taking the decision jointly with their husband. So who has the final say? The scale doesn't actually come up with it. But women alone has a very little say. So when you go for the scale, we'll find it out women alone has a very little say, whereas the respondent with the husband jointly have a more say. So therefore, it shows that they have a discussion, but who has taken that? So you can see here, we have done some work to understand that. Along with that, the same woman has been asked few more questions in the qualitative manner to find it out that why this kind of results has been come up. So we found it out that they are everything according to their mother-in-law. They have no choice and express their view. Then they said that my husband decide on the family planning because he earns and I have to take. So I agree. So I say that I cannot delay my pregnancy. So the more cultural context is more of the culture, more of the environment, more of the society where she sleeps matters. So how this has been addressed? We have actually worked with the norm shifting intervention to address the social and gender norm. We started working with the social pressure for the early childbearing, husband being the decision maker, inability to negotiate the contraceptive use, and reluctant to use the contraceptive among the first child. So increase agency and autonomy among the women. So that was the major thing which has to be worked on, and we have worked. So therefore, we had a model which has been come up very well taken by others and also replicated later on, which has been that interpersonal strategies, communicative strategies, linkage with the services and individual strategy. So you have an overall SBCC approach to actually improve the women are filling the gap which we see, which the scale and model has been find it out, and that has to be filled. Thank you.
Thank you, Dr. Lopamudra. Now the floor is open for question and answers. So I hope presenters can answer. So anyone can ask questions. I hope there will be a mic.
Can I start by asking a question from Dr. Nadika? Dr. Nadika, this on getting men involved in family planning, you had several recommendations. What would be if I gave you 3 things to tell us how we can programmatically get men more involved, what would be the 3 things that we can practically do?
Actually, so one thing according to my knowledge and experience, usually PHMs, they do home visits. So they discuss with these things with most of the time with the female spouse only. So they can discuss with both the spouses, male and female spouses. They are at the same place and discuss with both of them. Most of the time they discuss only with the female spouse. Male partner does not participate in that discussion. So that is one thing. And the other thing is, in our family planning clinics, most of the time only the female partner contributes. Even if the male partner comes, he just comes after the gate but does not come inside. So he should come inside and he should be there when the counseling is being done. I mean, both the couple should be there when the PHM or the doctor or the PHNS or someone discussing these things with the female partner. The male partner also should be there. The contraceptive counseling should be target both the partners. That is the second thing. And I think the other thing, because they have a lot of fear about these side effects and infertility, subfertility. So we have to address that part, because in my experience I have seen, even if the female partner accepts the method, later she comes to get it removed because the husband doesn't like to keep it. He thinks it can cause some kind of it can cause subfertility, infertility, any other harmful health effect like that. There are a lot of misconceptions. So that male spouses, that fear of side effects and potential for the infertility, subfertility, that aspect has to be addressed.
Thank you very much. I think that point is taken, educating the clients about the side effects. I think that's important. I think it also came up in another presentation. The first point you said, when the public health midwife goes to the house, most of the time, I did 3 household surveys in the month of October, and none of the houses had males in it because they had gone for work.
That time
So so the timing is a bit of a problem. So that is practically it's not possible, but encouraging the males to the clinic whenever they come, that's a possibility. And it's not all the time that the males accompany the wife or the female partner, but whenever they come, I think it's a good point to encourage them also to come to the clinic and listen to the counseling session. Thank you very much.
Hi, I'm Hasini. I'm representing ARROW, that is the Asian Pacific Resource and Research Center for Women. I think I saw a couple of studies where the focus was on the knowledge of women on contraception. From the point of view of civil society organization, my question also hinges upon what was just discussed about the lack of male participation in discussing family planning methods. Is there any reason why the studies were focusing only on the knowledge of females, women on family planning methods and educating women on family planning methods? Why wasn't there a gender neutral study when you sampled out your sample population? I think Migaras, and there was another study that followed which focused only on knowledge of women on family planning methods.
Thank you for the question. So, as I'm not a medical practitioner, so I am coming from a social background. So, when it comes to the males and females, main thing is majority of the sexual and reproductive health concerns are based on females, specifically for the 15 to 49 of reproductive age group. So that's why basically majority of researchers are mainly focuses on females. But in social sciences, we are trying to explain and elaborate how the men are actively participate for these kind of decision making and practice SRH related practices. But actually the thing you pointed out is very well taken in our researchers, because we have to have as you mentioned, in gender neutral manner, we have to study about those things. So as a social researcher, I will very well taken about that point as well.
For me, our study is an undergraduate study, so we have to select a study population that is feasible for us. So in the hospital setup only, we can get the most patients, most study population we can get. In that also, if you are going to take male population, you have to go to the medical ward. In the medical ward, most of the males are above the age of the reproductive age. So in the female also, we had a really tough choice which ward to choose. In that also, we couldn't choose any gynecology ward because they will have a problem in subfertility or infertility. Asking them these questions are not sensible. So we had to choose pediatrics. That is the only reason we chose the female population. In female population also, we asked about the condom use and what are the idea about male contraceptives. We asked about them. We couldn't access the male study population. That's the issue.
Hello, good afternoon. My name is Dr. Nilesh and I am from Family Planning Association of India. I have a question for Dr. Migara, and so it was a quite interesting presentation. Traditional methods versus modern contraceptive method. You presented in one of your slide, it says that by education and even by the sector, living place, or I think wealth quantile, more the education, more the wealth quantile, the traditional practice method use is also more, right? And then for the modern contraceptive also it says the same. That was quite confusing, that how come education increases and still modern contraception and traditional methods in the same age group, not same category, one variable like reading positive. It may happen, but how do as a programmer, it may statistically happen, but how do as a programmer you infer it? What's your suggestion? This is a question. And then just out of interest, I just wanted to know whether you explored when you were studying the traditional method, which to me appears quite high, the uses of traditional method in Sri Lanka as per your data. What's the outcome, whether it led to pregnancies or not? If I'm not sure whether you explored in your study, but just out of curiosity, the second question.
Thank you very much. Both two questions. For the first question, as you've seen in the slides, this is totally based on statistical analysis. But when it comes to grassroots level, there are so many different factors are contributing to those findings. So very basically, in most of the traditional family planning users, they are belongs to the highest wealth quintile. So it means that some sort of wealthier people are not preferred to use modern family planning methods. Just that they are believing on the traditional family planning methods. And also when it comes to the some sort of education level, that they think that they are in modern family planning methods, they are having some sort of myths with regard to the modern methods. That's why they're having those kind of things. Yeah. That's the thing. Because I have done very few interview-based study in our, because I am coming from University of Colombo, so some of the academia also having some sort of a beliefs that having some sort of infertility, subfertility, and some of the modern methods will cause some cancers. Likewise, if they use modern family planning methods than the traditional family planning methods. That's the thing with regard to that. For the second question, so high usage traditional family planning method, according to the DHS in 2016, around 13% of ever married women are using traditional family planning methods. The thing is, as I mentioned, there is a doubt between the practice, because as we all know that in Sri Lanka, we are doing so many promotions and awareness programs, but with regard to some specific groups, especially among some youth groups as well as some vulnerable groups, they are having some sort of issues or lack of awareness with regard to those things. And also, if they are using traditional family planning methods, they are having most of the women, those who are living in elder age categories among the reproductive age span, they are having some sort of elderly pregnancies as well. So this is some sort of a side effect, or it's not a side effect, but it's some sort of a bad thing in our, not in our society, but they are think that in Sri Lankan society, they are having children in their later ages. It's some sort of a not culturally accepted, no. So that's why they are having some sort of misspells regarding the birth control methods.
Just a little comment. I don't know whether your second question was answered. So you generally asked what the outcome was. Lots of people were using natural family planning methods, and what the outcome was. There were many unplanned or unwanted pregnancies. Probably that was the question he was asking. But his study was basically on the demographic health survey, which was done 8 years ago. Now in many countries, usually every 4 or 5 years, they do the DHS. Unfortunately, in Sri Lanka, the last one was done in 2016. But just on that, in 2016, the unmet need for contraceptive use was 7.5%. And at that point in time, we also have the National Electronic RHMIS information system, and our data was very comparable to the DHS. So at that point in time, our unmet need for family planning was 7.5, and the DHS also, the unmet need for family planning was 7.5. But since then, our unmet need has now come down to 5.4, and even the use of natural methods have actually come down. So the number of unplanned, unwanted pregnancies have also come down. So that's like a comment for your question. Thank you.
Dr. Lopamudra is also online, so if you have questions for her also, you can direct your questions. Any more questions?
Yeah, hello, I'm Madhushmita. I'm from India. I'm a student in social work public health. Me and my friends studies also on cultural and social barriers to family planning. I don't know the context of Sri Lanka, so when he was presenting, how education might not necessarily lead to use of modern contraceptive. So I want to understand if in Sri Lanka, what might be the social determinants then? Like what are the factors that might influence? If it is not education, then is it the culture, the religion? I don't know, like if you could find out any other reason for non-use of modern contraceptive.
As I mentioned, there are so many factors which contribute to the traditional methods usage. The thing is, actually, as doctor said, that nowadays we are having a very low level of practice usage of traditional methods, but still we are having some sort of a percentage that we have to address. Actually, I think, as you mentioned, there are so many cultural and religious backgrounds are affect on those practices. As if you heard about listen to the plenary sessions at the morning, so they also said that there are some political as well as religious interferences are there with regard to the knowledge and everything. So in most of the Sinhalese, Tamils and Muslims are having very in-depth religious background. So most of their practices with regard to their marriage, their child preferences as well as their family planning methods and everything are having direct and indirect effects on their family planning behavior. So that, as I think, as a social research, I think mainly rather than education level, based basically the culture, religion, and other factors also directly and indirectly influence on the usage. I hope you got the answer.
Yeah, I think we can have one last question. Yeah.
Generally, family planning people use either any contraceptive method. But the thing is that whether it's in India or in Sri Lanka, the use of modern contraceptive methods is around 50-60%. A medically ill patient will take a medicine. But people using family planning are not patients. They are clients, they are otherwise healthy. So taking a medication, whether it's a pill, whether it's using a IUCD, it is an intervention. And always people are afraid of side effects. And whatever little side effects are there, they are blown up. So that is why whether they are educated, whether they are wealthier, they still fear using modern methods, and that's why they use the traditional methods. Or they don't use any method. Even I have seen educated people not using any contraceptive methods for the fear, even the modern contraceptive method, for the fear of having side effects. They can take any amount of antibiotics, any amount of analgesics without asking for side effects because they are suffering. They have pain or infection or whatever. But a person using a family planning method is not a diseased person. He or she is a healthy person. And when you want to use an intervention, you're scared of side effects. That is the main reason why people don't use contraceptive methods. And it is our duty to educate them about the better effects of using contraceptive and the bad effects of terminating an unwanted pregnancy. Thank you.
So thank you very much everyone for.
As Madam said, some are preferring the natural method because that is less side effect, but that's not true. Because if it's a medically proven thing, we know the side effects, we know which dose causes which adverse effects, we know that. In the traditional method, no studies have been done, pharmaceutically not approved. So many of them, most of the time in Jaffna also, last year one case happened, one taking an Ayurvedic medicine, she came with a massive liver failure. If she had taken the normal medication given in the hospital, it wouldn't have caused that much of an effect. And in the contraceptive also, if they are gaining weight, that is not because of lipid deposition, it is because of the water content is increasing in their body. So we have to give a proper idea about what is the problem with the traditional method, what are the problem with the modern method. We have to clear both of them out.
So thank you very much. Because we were behind schedule, I would thank everyone, all the presenters and the participants for your active contribution, and also I thank my coach and my classmate for supporting me. Thank you very much. We will present the certificates for the presenters, Ms. P. Vinakar, Dr. Vinakar. Tapasi Grahacharya, Vaishnavi Vengadiswaran, Dr. P. Lopamudra. We will send the certificate.